section we will review pulmonary vascular issues, infections in the lungs, as well as complications from lung transplant. With pulmonary hemorrhage, there's an acute intra-alveolar hemorrhage, and macrophages can be hemorrhacidin-laden. This needs to be stained with Prussian blue stain for iron. This is normally done under a BAL or bronchoalveolar lavage. Saddle embolus, as seen in both the left as well as the infarction due to a pulmonary embolus, is seen in the right. Pulmonary vascular disease. Primary pulmonary hypertension has an unknown etiology with a very poor prognosis, usually in the absence of other heart and lung disease states. Now, there are more medications used for primary pulmonary hypertension, but it still has a very poor outcome. Secondary pulmonary vascular disease, or secondary pulmonary hypertension, is normally due to a secondary process, such as COPD, increased pulmonary blood flow, such as a left to right shunt, embolism, or chronic hypoxemia, as well as increased blood viscosity, such as polycythemia. The clinical features of both primary as well as secondary pulmonary hypertension includes dyspnea and fatigue and eventual right heart failure. Pulmonary infections. With a bacterial pneumonia, you have to realize that it's an exudative consolidation of lung parenchyma, meaning there are several different kinds of disease patterns. With bronchial pneumonia, you're going to have a patchy consolidation of the lung. The etiology normally includes Staphylococcus aureus, Haemophilus influenza, Streptococcus pyogenes, Pseudomonas aeruginosa, or Klebsiella pneumonia. These 5 entities are the most common causes of your normal community-acquired pneumonias. Lobar pneumonia is consolidation of the entire lung and is usually due to strep pneumonia, but can still be due to any of these other bacterial pathogens. Interstitial pneumonia, or diffuse interstitial process, can be due to mycoplasma, which is the most common. Mycoplasma also can cause epidemics. Another cause for interstitial diffuse pneumonia is viral causes, such as influenza. Rickettsial diseases or Q fever can be seen in cattle workers as well as those who intake unpasteurized milk, and this is due to Coxiella burnetii. Ornithrosis or cysticercosis is normally due to chlamydia cysticercosis and is with exposure to the excrement of infected birds, pigeons, or even bats. Other types of pulmonary infections include pneumocystis carinii, otherwise now known as Cervici, or PCP, and this is normally found in opportunistic infections in immunodeficiency people, such as those with HIV/AIDS or undergoing chemotherapy. Pneumonia bug points. Let's review this in detail. Strep pneumonia. Realize that it can be seen in elderly, debilitated, or malnourished, and strep pneumonia can lead to empyema. Staph aureus is normally a secondary infection or from IV drug users. It can lead to endocarditis as well as brain and kidney abscesses. One thing with Staph aureus is it can cause a lot of hemoptysis. Strep pyogenes is also complicated by influenza or measles, and this can cause lung abscesses as well. Klebsiella, just like strep pneumonia, is normally seen in debilitated, elderly patients, diabetic, or some alcoholic patients as well. Haemophilus influenza is normally seen in infants, children, and COPD patients. It can cause meningitis as well as epiglottitis. Legionella pneumophilia is seen from those exposed to contaminated stored water. Another bug that needs to be recognized is listeria. If someone has listeria, they are often in elderly patients, and you need to recognize that soon. In terms of pathogenesis for bacterial pneumonia, With the pathogenesis, there's a failure of the defense systems, so the pneumonia results when this defense system is impaired. It can be due to a deficient mucociliary ciliary action, or deficiency in nasal clearance, or just a chronic onset of oxidants and bacteria. Normally, you'll have a problem with alveolar clearance, phagocytosis by alveolar macrophages. There will be a loss of suppression of the cough reflex. Sometimes aspiration of gastric contents can cause a pneumonia, as well as pulmonary congestion or edema. One of the most common causes for pneumonia in cystic fibrosis patients are the accumulation of secretions and the inability to clear their mucus plugs. Clinical features of bacterial pneumonia include malaise, chills, fevers, cough, and occasional rusty sputum or hemoptysis. Patients can also have pleurisy or pleuritic pain, as well as a pleural friction rub. Lung abscess are a problem both with bacterial pneumonia as well as bacteria that is spread hematogenously. Normally, with a lung abscess, you have a local suppurative process within the lung that is characterized by necrosis within that lung tissue. It can be due to Staphylococcus aureus, Pseudomonas, Klebsiella, or any type of anaerobes. Normally, if it's an anaerobe or a gram-negative, it's due to aspiration. Also, you can have septic emboli as well as malignancy that can cause a lung abscess. The issues and clinical features of lung abscess includes fever, cough, a very foul-smelling sputum, and chest pain. Also, chest x-rays as well as CTs will demonstrate a fluid-filled cavity. Tuberculosis. This is one of the main infectious entities that can never be forgotten. The pulmonary form is spread by droplets of Mycobacterium tuberculosis. There are also non-pulmonary forms that is often caused by ingestion of milk. Pulmonary tuberculosis subtypes include primary and secondary pulmonary tuberculosis. Primary pulmonary tuberculosis normally deals with the Gone complex, which is parenchymal subpleural lesions. This can be a progressive spread with cavitation and tuberculous pneumonia, miliary tuberculosis, as well as Pott's disease of the spine and TB meningitis. Pott's disease of the spine is when you have a TB infection of the vertebra that actually causes compression fractures of the spine. Secondary pulmonary tuberculosis is normally due to a reactivation of the prior Gone complex. In these patients, you will have fever, hemoptysis, pleural effusions, as well as chronic cachexia and wasting. The pathology shown in a secondary pulmonary tuberculosis demonstrates localized lesions in apices, as well as sometimes involvement of the hilar nodes. Cavitary lesions are also unique for a secondary pulmonary tuberculosis. This slide demonstrates a Gone complex. Notice the arrows. The gray-white parenchyma focus under the pleura in this topmost arrow. The hilar nodes also demonstrate a caseated granuloma. Lung transplant complications. When patients have pulmonary arterial hypertension or idiopathic pulmonary fibrosis or another entity such as cystic fibrosis in which they are going to lose their life, lung transplantation is desired. Complications of lung transplantation include pulmonary infections, acute rejection, as well as chronic rejection. With acute rejection, you will have mononuclear cell infiltration around the small vessels as well as the submucosa of the airways. This ends this section.